So my name is Darren Kies. I'm an interventional radiologist and diagnostic radiologist for Piedmont South Imaging. Patients with hepatocellular carcinoma that are being considered for treatment with Y-90 radioembolization have to first undergo a study that people kind of colloquially will refer to as a shunt study. Some people will call it a pre-treatment planning study. There are a lot of different names, but the idea behind it is that one, you need to map out this patient's blood vessels at angiography so that you can, determine what the anatomy is, plan how you're going to deliver your radiation therapy, and make certain that there are no non-target embolization sites where your radiation could potentially go and cause complications. The second part of the pretreatment study is to deliver a test dose of radiation. It's actually not Y-90 that we deliver. We use something called technetium MAA. It's a very, very low dose of radiation. MAA stands for macro aggregated albumin. It's about 4 millicurie dose, and it roughly approximates the size of the particles that are used for Y-90. And the purpose of injecting it is to make sure that it traps appropriately within the liver and the tumor that you're targeting and doesn't get through to the lungs. The way we determine that is that, after we inject this dose of radiation, which is usually the last thing you do at the end of your planning angiography, you bring the patient over to nuclear medicine and you get anterior and posterior planar images of the body, of the chest and the abdomen, and sometimes you use SPECT CT as well. And then you basically just measure a percentage. You look at the activity over the lungs and you compare it with the activity over the liver, and you figure out what percentage of that dose went to the lungs. Everyone shunts a little bit. Any normal person is going to have somewhere from a 3 to 5% shunt ratio of some of these particles that make it through the liver and end up in the lungs. But some tumors, most notably hepatocellular carcinoma, have an increased incidence of having a high shunt fraction. And the significance of that is that the higher your shunt fraction, the more radiation during a Y-90 treatment will go to the liver, and there's only so much radiation that you can safely deliver to the liver, to the lungs, without the risk of having long-term consequences such as pulmonary fibrosis. We usually look at that based on dose. So on any given treatment session, the lungs can tolerate up to about 30 gray of radiation to the lungs. And over a lifetime, you don't want to deliver more than 50 gray. And at that point, it would increase your chances of getting pulmonary fibrosis. So there's really no upper limit as to what the shunt can be in terms of a percentage. It used to be thought that, at 20-25% that patients wouldn't be a candidate for Y-90, but really what's important is the actual dose that they're going to receive to the liver. Furthermore, there are procedures now that people will do to try to reduce that shunt fraction, whether it's doing kind of a pre-embolization to try to shut down some of those shunts that are present between the arteries and the hepatic veins. Some people will even use a low dose of Y-90 and then repeat the shunt study to see if you can bring patients within range so that you can treat them effectively. But that's the main purpose of the study, to make sure that your radiation is going to be where it's going to go. The first part of it, which I already mentioned, is the planning angiography, and that's just as important. You want to make sure that you can get a catheter where you need to get it within the bloodstream, and that you can deliver the radiation in a fashion that you're going to get an effective treatment. And some of it depends on the strategy that you're employing. If you're treating a patient with metastatic disease and you're going to be treating both lobes of the liver, generally you're delivering the Y-90 via the right hepatic artery and the left hepatic artery. And in those cases, you want to make sure that there's no anatomic variance coming off the hepatic arteries that would lead to what's called non-target embolization. When Y-90 first came out, it was very routine to just empirically embolize the gastroduodenal artery and the right gastric artery. These are two vessels that usually, the gastroduodenal artery is usually one of the first branches off the common hepatic artery, and signifies the split between the common hepatic artery and the proper hepatic artery. And it's right there usually when you're delivering. And if you get reflux of particles down the gastroduodenal artery, that's a blood vessel that supplies the duodenum, the pancreas, and continues on into other parts of the gut. and radioactive particles in the gut can cause ulcers, which can be, can cause significant morbidity. So it used to be routine practice to empirically embolize the gastroduodenal artery and the right gastric artery to avoid non-target embolization to the bowel. Nowadays, especially with some of the ways that we're delivering these radiation doses and the places you can put your catheters, you don't always have to routinely embolize these vessels if you feel you have a safe distance from where you're going to be delivering to where the first point of reflux is. But there are other anatomic variants that any interventional radiologist needs to be aware of. There are accessory gastric arteries that can oftentimes come off the left hepatic artery that need to be identified and need to be treated to avoid delivering a treatment dose to the stomach or a portion of the stomach. There's another interesting vessel called the falciform artery that is kind of a fetal remnant that some people have that remains patent, and it's quite small and difficult to see. Oftentimes you don't even see it on angiography, but on your nuclear medicine study on follow-up, you see some activity near the belly button. And if you can see it, you can identify it and you can embolize it. If you can't see it, but you notice it on your shunt study, you can place an ice pack over the belly button to cause vasoconstriction, and that usually prevents issues with embolization to that area. If it were to happen, the consequences that you get, kind of a dermatitis and a skin rash, and it's usually self-limited and not severe, but it's something that we like to avoid as well.